University for Women RN to BSN program to give y'all a brief presentation on hypothyroidism. Since y'all deal with those patients every day, we thought it'd be a good review. We'd like to thank y'all for coming out and taking your time out of your busy work schedules to listen to us. My name is Julie, and I'll have two other co-workers up here with me soon to speak with you as well. First, I've given y'all all a printout of the PowerPoint, so if you could just follow along with me. We would like to first go over the objectives. And pay attention because this is what will be on your test. No, this one. All right. By the end of this presentation, you all should be able to state 2 risk factors of hypothyroidism, list common signs and symptoms of hypothyroidism, acknowledge current treatments available, give a list of at least 4 of the top 10 problems related to this disease, and list 1 support group or site available for patients suffering from hypothyroidism that you could send them to for references. I'm going to introduce y'all to Jason. He's going to come up here and start it, and then we'll go through it. Let's go.
Good afternoon, guys. My name's Jason. All right. We're going to start by talking about what the thyroid gland is, and pretty much going to educate you on hypothyroidism. We all know what the thyroid gland is. It's a hormone-producing gland that's anterior portion of our neck, and it's responsible for the body's metabolism and pretty much affects critical body functions like heart rate, energy levels. And what is hypothyroidism? It's an endocrine disorder which the thyroid gland doesn't produce enough thyroid hormone. Most common disorder is thyroid function. To go over a little bit of history, goiters were treated all the way back 2700 BC to 1100 AD with seaweed. And later, hundreds of years later, they found out that by burning seaweed, it produces iodine. And that basically, by the time you got down to mid-1800s, they were producing iodine to treat goiters. But surgeries even dated back to 1170 AD, and but the mortality rates were extremely high because they didn't have any documented drawings of the gland. They were just tearing it up, so vascular. Success rate was like very low. Let's see, by mid-1800s, thyroid surgery had less mortality rates due to more illustrations of the gland itself. Success was a little bit higher. By 1862, Graves' disease was introduced. 1917, thyroxine, which is used to treat hypothyroidism, it was in commercial distribution. And by 1949, needle biopsies become the most common diagnostic procedure for your regular blood work you have these days. And we're going to talk about incidence of hypothyroidism. Approximately 12% of the U.S. population will develop hypothyroidism. 20 million currently have the disease, and 60% of those people are unaware they have it. Women are 5 to 8 times more likely to develop hypothyroidism than anybody else. Prevalence amongst ethnic background, Caucasian are usually 5.1%, Hispanic 4.1%, and African Americans are 1.7%, which are the lowest. Risk factors that are associated with hypothyroidism are a strong family history of it, with genetics, autoimmune diseases such as lupus, as well, and that's especially important to me because I wear lead all day during procedures I do at work. Very important I wear lead vest and thyroid collars to prevent those that risk factor. Genetics, genetic syndromes such as Turner's and Downs also also have a major risk factor for thyroid disease, as well as obesity. Causes, we've got a primary cause, which is autoimmune thyroiditis, which is can be Hashimoto's disease, which presents itself more like water-like symptoms, but it's a longer process and it's more chronic. Surgically removed thyroid is a cause of hypothyroidism. Iodine deficiency in certain medications. I think like lithium and amiodarone, cardiac drugs, can cause that. Secondary causes can be hypothalamic disease, pituitary disorders or diseases, pituitary tumors, brain tumors, traumatic brain injuries, and subarachnoid hemorrhages. Thank you.
All right, I'm going to start by giving y'all a little pathophysiology of hypothyroidism. Hypothyroidism occurs gradually. It doesn't typically just hit you all at once. It's going to happen over months and years. You might not notice it at first. Originally, there's going to be a decrease in the thyroid hormone levels that lowers your metabolism. It lowers your heat production. You'll feel cold all the time. The patients typically develop a low basal body temperature and have a cold intolerance. Decreased thyroid hormone levels lead to excessive TSH, which is the thyroid stimulating hormone. So you get excessive TSH. That's gonna it's a production which stimulates the thyroid tissue, which causes the goiter. So when you get excessive of that, that's when you'll notice they have the bigger thyroids and they feel the goiters. Affecting the body systems, it's typically going to affect all body systems. Now, not everybody's signs and symptoms are going to be the same, but generally, neuromuscular effects of it are going to have slow thoughts and speech, slow action, lethargy, fatigue, sleepiness, muscle aches and weakness, and slow reflexes. You think of hypo, you think of low. Everything's slow. Cardiac-wise, bradycardia, decrease in contractility, and pericardial effusions, and it can lead to CHF if left untreated, but those are typically extreme cases. Common signs and symptoms. I'm just going to go over, there's quite a little few of them. Fatigue, weight gain or difficulty losing weight. I know I always like to diagnose myself with hypothyroidism. Weakness, coarse, dry hair, hair loss, dry, rough, or pale skin, cold intolerance, like we spoke about a second ago, constipation, depression, irritability, memory loss, decreased libido, abnormal menstrual cycles, muscle cramps, and frequent muscle aches. Now, each individual patient will not have all of these, and they'll have a number of these symptoms. They will vary depending on how long they've had hypothyroidism and how long it has been untreated. You may have one of these as a main complaint, while another will not have that much of an issue with you. Most people will have a combination. Occasionally, some patients with hypothyroidism will have no signs and symptoms at all, or they're just subtle, they go unnoticed. On the next page, you'll see our little picture. This lady, and she's wrapped in her scar and everything, and so showing how the signs and symptoms affect her body. She's cold. She actually looks like she's squinching her little bottom. She's constipated. Menstrual disturbances, brittle hair, and nails. All right, diagnosing. How do we diagnose hypothyroidism? Are there specific tests? Diagnosis is typically made by about three main things: the medical history, so you talked about family history, genetics, physical exam, and lab work. The physician typically examines all your systems, because remember, it affects all of them. So you got cardiovascular system, skin, hair, eyes, reflexes, and body temperatures. The diagnostic lab work, we're going to go over a few of the things that might not mean a whole lot, but I know you've seen them on your lab work. Serum thyroxine, which is T4. Normal levels are 4.6 to 12. Serum triiothyronine is T3. 80 to 180 is normal. Serum thyrotropin, which is your THS, the thyroid stimulating hormone, is 0.5 to 6. And they'll also do an antibody test. High levels indicate the Hashimoto's thyroiditis. Abnormal lower levels of T4 and T3 indicate that you have hypothyroidism. CT and MRI workups are sometimes probable if the diagnosis indicates a problem, like if they need to look at the thyroid and get a closer look and see if it's enlarged. Prognosis. There's no permanent cure, but it is easily treated. It's typically a lifelong treatment. Once you start taking the medication, you will have to take it for the rest of your life. If untreated in children, it can lead to an impairment of growth and development, common and preventable causes of mental retardation in children. Severe hypothyroidism, if it goes just so long you don't treat it or you do not take your medicines. Extreme cases, you always have to have an extreme case. Worst case scenario is the myxedema coma. This is triggered by severe illness, trauma, stress, and surgery. Just anytime your body gets under stress, if you have a disease and then you're not treating it, it's going to worsen it. It requires immediate treatment and hospitalization. You can go into respiratory distress, and it's a coma. Your body shuts down. Treatments of hypothyroidism. There's a daily dose of levothyroxine or Synthroid, which most of us know the name of it. Levels should be timed appropriately. Regimen and dosage depend on the individual's age, the duration and severity of the disease, the presence of other disorders, particularly cardiovascular, because you have to see how the medications work with your other issues. After dosage stabilization, after you get everything like it's supposed to be and your levels correct, the levels are monitored with an annual or semi-annual clinical evaluation. You'll go get lab work drawn. Hypothyroidism can be adequately treated with a constant daily dose of the levothyroxine. But you have to be careful for overtreatment. If you take too much and your levels get too high, you have a risk of going into hyperthyroidism. You watch for signs and symptoms of this overtreatment, which include tachycardia. Everything now is high. Everything's low with hypothyroidism, now everything's high. Palpitations, go into AFib, nervousness, tiredness, headaches, increased excitability, sleeplessness, tremors, and even could have some angina possible with that. Surgery. Do you think you'll ever need surgery if you have hypothyroidism? It's rarely needed with hypo. Typically, if you have to have surgery in your thyroid, it's going to be because you have hyperthyroidism. The only time it's usually indicated with hypothyroidism is if you have a goiter and that's compromising your breathing or tracheoesophageal function. I'm going to get Kelly up here now, and she's going to talk to you a little bit more about impact on daily life and some ethical issues with hypothyroidism. Thank y'all.
Thank you.
Okay, my name is Kellie Watkins, and I'm a nursing student at MUW, and I'm going to be talking to you today about ethical issues related to hypothyroidism, also the impact that the disease has on the individual, your family, and society, and also about the care plans for the patients that you'll come in contact with this disease. So the first thing is ethical issues with hypothyroidism. Well, if they have severe hypothyroidism, you question the patient's ability to give genuine informed consent for surgeries or any kind of procedures. Are they capable of giving an informed consent? If there's severely hypothyroid patients who drive machinery or work or in critical occupations such as air traffic control, they may be agents of harm to third parties. So that's something, ethical issues that might come up in your practice in nursing that you may have to address. But it's rare, but it does happen. It's another, TSH levels is how you diagnose hypothyroidism. If their levels are really high, you could compare them to someone with that drinks alcohol, their alcohol levels being high. They may not feel impaired, but they may make decisions that may risk harm to others or themselves. So basically, without informed consent, patients cannot reasonably exercise their autonomy. And they may require a surrogate decision maker. Second of all, how does hypothyroidism affect individuals, family, and society? Well, personally speaking, I do have hypothyroidism, and it does affect me if I don't take my medication. If I miss one dose, I can tell. I feel cloudy in my thinking, and I feel tired, fatigued. I feel just really like I'm dragging. So it does affect the individual, and it can affect the family as well. Some misconceptions of people with thyroid conditions are that they're unmotivated, they're always sick, tired, and lazy, when in fact the opposite is more a reality, and they want to be a part of the real world at any time. The wider community does not appreciate that people with this chronic illness have difficulty filling the multiple social roles required of all members of the community. Because this is a lifelong disease and illness that has to be treated with medications and lab work to maintain a therapeutic level, this will affect your physical, psychological, and psychosocial aspects of your patient's care. Also, for women that are trying to conceive, hypothyroidism may interfere with ovulation, which will cause infertility. So that may affect your marriage. It may affect the mother that wants to have a baby. So that could also become an issue. It also can become a financial burden, paying for medications, doctor bills, and other treatments. Decreased energy levels can affect family activities and workload. So you may want to, when discussing this with the patient with hypothyroidism, you can refer them to different support groups that they can get some information that may help them in dealing with this disease. Thyroidsupportgroup.org, also dailystrength.org. Lastly, when you're doing your care plans for your patient, the top 10 problem list that we have come up with, the first one being lethargy and fatigue, second, forgetfulness and loss of memory. These patients with hypothyroidism deal with weight gain, bradycardia, cardiac enlargement. People with hypothyroidism pretty much have a tendency to develop congestive heart failure, cardiac disease, unfortunately, constipation, general puffiness and edema around your eyes and face, intolerance to cold, weakness, muscle aches, and menstrual disturbances, like I discussed earlier with infertility. So the top 5 nursing problems and developing your care plan, the first one being lethargy and fatigue. Some of the things you can take into consideration when you're preparing your care plan for that patient. You want to encourage them to share their feelings about the effects of the disease on their life. You may want to refer them to their support groups to get information to help them and their family. You can educate the patient on 4 energy-saving techniques. There are several different ways that you can go about dealing with lethargy and fatigue. Forgetfulness and loss of memory. Encourage your patient to make a list or to keep a journal. Weight gain is the third problem. You can, when you get ready to assess the patient, you assess their height, weight, and BMI. You can also have someone from dietary come in and help them establish a meal plan to help establish a well-balanced diet and reduce calories and fat. You can set a weekly goal for weight loss, and also they can have a friend to hold them accountable and work with them and maybe start an exercise regimen. Bradycardia is the 4th. You want to assess the patient's heart rate and blood pressure, peripheral pulses, skin color and temperature, assess their heart sounds, lung sounds, and response to increased activity. And the last one, cardiac enlargement, tendency to develop congestive heart failure. When you are developing your care plan, you want to assess the patients for symptoms of dizziness, weakness, fatigue, nausea, vomiting, confusion, sweatiness, cyanosis, and notify the physician if appropriate. Assess for presence of edema, check breath sounds, assess for labored breathing, check vital signs, keep the head of the bed elevated, monitor their fluid intake, monitor their lab work, specifically potassium, sodium, BUN, and creatinine, and weigh the patient daily. So that is your care plan for the patient with hypothyroidism. So basically, the reason we chose this subject is because it interests me because I deal with it every day, and it does affect you, especially, you know, like I said, if you don't take your medication. And but if you do, there is a great outlook, and it is something that you're able to live with, and you don't have to, it doesn't have to affect your life. So, but that's from a personal aspect, but this is to take to your patients and to help you with understand them better. So I really appreciate all of you coming and listening, and I hope this helps with you dealing with your patient with hypothyroidism.
Good job. Good job.